Good morning or afternoon. I'm Celia Kaye. I'm a pediatric geneticist, and I had the honor and privilege of being the program director for TextGene back in the early days of the regional networks, and then for Mountain States Regional Genetics Network and Regional Genetics Collaborative. We've done many names over the years, so it is my pleasure to have this time to talk to you about what I remember and what I loved and what I continue to love about the regional networks. I think you all know that the regional networks were started by HRSA, the Health Resources and Services Administration, which is one of the three big branches of health and human services in our federal government. The other two big branches are the NIH and the CDC. But HRSA is specifically charged with making sure that people have access to medical services in our country, and particularly it's aimed at underserved populations in our country. So back when HRSA decided to start regional networks, which was back in the 1980s, genetics was a puzzle to many, many people, physicians and patients. The human genome was nowhere near being sequenced, and genetic contributions to most common diseases and even to many rare diseases were really not understood. They knew they were there, but we didn't have the genes. We didn't have the technology to try to understand how those contributions really worked. So HRSA decided that because genetic services were becoming important, that they needed to do something to make sure that underserved populations had access. Back then, most genetic disorders were untreatable. There were few laboratory tests. So it was a different time. State newborn screening was present, but just for a very few diseases, and there was very little treatment for most of the diseases that you might have been able to diagnose if screening programs had taken them up. Anyway, the regional networks were supposed to bring geneticists together, state health departments together, and uniquely, the networks were supposed to bring what we called consumers, what we still do, but our patients and their families into the conversation to see how genetics could become part of regular medicine. I first got involved with the regional networks back when I was recruited to Texas with my husband in 1989 to the University of Texas Health Science Center in San Antonio. Again, back then, almost all genetics programs were university programs. They were too expensive. Billing and collecting was primitive, and it wasn't possible to be a private practice geneticist in most settings. So the universities were very involved, and HRSA created the genetics networks then, with TextGene being the only one state network. There were 10 networks altogether. TextGene, we hypothesized, was a single state network because nobody else wanted to work with Texas, and if that was true, that was a mistake. But TextGene had a great time being a single state network and getting the large number of geneticists together within the state to work together. I want to stress that health departments were an important part of the regional networks from the beginning, and newborn screening was brought into the picture, as well as maternal and child health bureaus within states. Now, we were, of course, west of the Mississippi, and genetics programs were few and far between in the 1980s in this part of the country. So there were many states within regional networks that had no genetics providers at all. And it was critical that states work together to fill gaps in other states, to help each other at the state health department level, to help each other with newborn screening technology, and to get consumers who were crossing state lines in order to get genetic services into the mix of actually becoming served. Again, I want to emphasize that families and patients were a critical part of the networks from the beginning. This was a HRSA vision, and we knew if underserved populations were being served because the families were there and they could tell us, and they were in leadership roles where they were heard. To coordinate the networks, HRSA created the Council of Regional Networks, or CORN, C-O-R-N. CORN was a fairly primitive committee at the time, didn't have a lot of power, but had a lot of really well-motivated people who wanted to see that genetic services got to the people who needed them. It was recognized right away that there was no data repository. We didn't know who was being seen by genetics providers. We didn't know who they were, their demographics. We didn't understand what their diseases were. So Corn tried to make a minimum data repository, and they did come up with a system. But remember, this was the 1980s. Computers, of course, existed, but they were not highly available within the medical setting. There were no electronic medical records. We didn't speak to each other over the internet. We spoke to each other by telephone, by snail mail, and by sending in forms. So, because HRSA wanted us to collect data, and we were regional networks who were funded by HRSA, we started to collect data on paper forms. There was minimal funding for this really massive effort, but we filled out forms on every patient. We summarized the forms at the end of the year, and we sent them in to the CORN committee on the minimum data set. As you can understand, data were incomplete. There was no real quality assurance. And Dr. Jane Lin Fu, who was the genetic services branch at HRSA at the time, chief at HRSA at the time, being a meticulous scientist in her own right and a physician, was very frustrated at the quality of the data that we were able to collect. There was a giant in genetics at the time, George Cunningham, who was chief of the genetic services department in the state of California. George had a lot of money through his state. They had an excellent genetic services program, and he was able to collect data. He became the guru overseeing the quality of the data that were collected through this minimum data set. And Jane, genetic services branch director, looked to George to see if the quality of the data was adequate for the purposes that she had. Back then, we had annual meetings with HRSA, just as have been happening ever since. And Jane would look at George and she would say, "George, do we have data?" And George would shrug and say, "Maybe next year." And the next year would come and Jane would say, "George, do we have data?" And George would shrug and say, "Maybe next year." Finally, one year, Jane looked at George and she said, "George, I'm afraid the emperor has no clothes. George, does the emperor have any clothes?" And George, who was rarely silent, was quiet for a few minutes, and then he shrugged and he said, "No, Jane, the emperor has no clothes." That was actually the end of the minimum data set, and before long, that was the end of the first iteration of the regional networks. But when the regional networks went away that first time, something important was lost for genetics. First of all, the emphasis on sharing resources between states that were close to each other but with inadequate resources was gone. We no longer had regular meetings. Of course, relationships that had been built continued to exist to some extent, but there was no resource to bring state health departments, genetics providers, and families and patients together to talk things over and come up with solutions. So that was a big loss. The whole focus on the consumer was diluted with the loss of the original regional networks. And newborn screening, which had finally found a place within clinical genetics, went back to the states and was no longer fundamentally incorporated into discussions of clinical services. Well, HRSA realized that something major had been lost, and so the regional collaboratives were created, and that was the Mountain States Genetics Regional Collaborative. I was contacted by Michelle Perrier, who was the genetic services branch in 2007 and 2008, and I was asked to be the program director for the Mountain States Regional Genetics Collaborative. I lived in Colorado at the time, and I was very glad to bring my second state into the Mountain States. Fascinatingly enough, Texas now was included as one of the Mountain States in the 7 collaboratives that were created. I think the Mountain States were happy to work with Texas, and Texas brought a tremendous amount of knowledge, experience, and fervor into the picture, so that Texas became a really fundamental member, as did all of the states in the Mountain States. I do want to remind you that Texas does have mountains. It really is okay to see Texas as a mountain state. The whole middle of Texas is flat, but the western end has mountains that are over 7,000 feet. So we felt justified in being one of the mountain states. Now, once the collaboratives were formed, and they eventually became the networks again, once the collaboratives were formed, wonderful new things came into being. As you know, methods for newborn screening had exploded. And those methods now could be shared amongst the various states. Again, highly qualified people in state departments helped each other where resources were more limited, where knowledge was not as rich. They talked to each other. They helped each other with methodologies. They solved problems for one another. At that time, a uniform panel for newborn screening was being developed. The networks allowed that uniform panel to become widespread across the United States. The Secretary's Advisory Committee on Heritable Disorders in Newborns and Children, SACADONC, our well-loved committee, began vetting new disorders to be added to the newborn screening panel. That information was widely disseminated. Families within states were able to participate in the process, and new disorders were added. So a lot was done through the regional collaboratives and the regional networks, and they have served a tremendous purpose in making genetics a clinical specialty that actually reaches people, particularly underserved people. For me, I have so many fond memories of TextGene, the collaboratives, and the regional networks. Of course, the close, wonderful working relationship with Texas Health Institute was so meaningful to us. THI made this work for the mountain states, and we had many long conversations, many struggles over getting the grant just right, and THI was there as a partner throughout the entire time. I think the regional meetings with families were amongst the most meaningful to me in all of this association in TextGene, in the collaboratives, and in the regional networks. We sat down together, we talked, we understood some of the struggles that families were having, and they were able to speak as equals within the planning functions of mountain states so that their role was clearly leadership and clearly very important. I especially value the time with tribal representatives, and I can't stress enough how struck I was and continue to be with the beauty of the American Indian culture, with the warmth and commitment of these individuals who worked hard daily to bring services to people who are very much in need. I especially remember a meeting at Diné College, which is a Navajo community college, where we were given the opportunity to meet with tribal leadership, with the IRB, which had banned genetic testing in the Navajo Nation, with families who wanted their children to get genetic services if those services would help their kids. And it was a tremendous opportunity to see how things worked within the tribal community and to appreciate the warmth, the fervor, the compassion, the beauty of the American Indian culture. I also valued those wonderful annual or semi-annual meetings with HRSA, where all of the networks got together. And I want to say something especially thankful to Celia Au, who was the Hawaii genetics branch director in the state of Hawaii, who brought us delicious macadamia nuts and other treats from Hawaii every time we had a meeting. So I say goodbye to the regional networks and especially to mountain states with fondness and with regret. Genetic services are at a different place than they were in the 1980s, obviously. Technology has changed, access has changed, professional and public understanding has changed. People may still not understand exactly what genetic services are, and by people, I mean professionals as well as patients and families. But they do understand that genetics is a part of medicine and that new diagnoses and new cures are coming on a regular basis. And I don't think that the role of the regional networks and the collaboratives can be understated should not be understated, cannot be overstated in how important that role was in getting the word to the profession and to the public. So I'm grateful to have been part of this. I'm so grateful to Mountain States, the staff, and to THI for all the support I was given and for all the friendship and love that I felt coming from this network and from the families and professionals that are in that network. And I believe that the regional networks have contributed greatly to the growth of clinical genetic services in our country, and I am so glad to have been a part of it. Thank you.